Okay, so now we've hopefully got online Kirstine Metcalf, who's joining us from Sydney because she's down there for another thing today. Kirstine's talking about combating malnutrition, one bite at a time. And her presentation is about the journey in developing an allied health residential aged care team focusing on improving the nutritional status of our residents in our multipurpose services centres by improving the mealtime dining experience. Kirstine is the nutrition manager and renal dietitian within Western New South Wales Local Health District, Dubbo Health Service. And she has a really big interest in frailty and aged care and provides a holistic approach to her clients, many of which are aged and are frail, and is a strong advocate for equity in rural health care, which is a really important thing out here.
Thank you. So as Ash has stated, we're looking at the combating malnutrition one bite at a time within our multipurpose centres. So this was undertaken, next slide please. This was undertaken, it started in 2022. So just a little bit of a background about Western New South Wales Health. So we're the second most sparsely populated LHD in New South Wales, roughly about one person per square kilometre. So it's across a very large distance of area. Our population is definitely ageing. And central and northern cluster covers an approximate area of a quarter of New South Wales. So this just gives you a bit of perspective about the area and distance that my RAC team is covering. So looking at it, in 2021, we've got that ACHS accreditation process and the Royal Commission into the Aged Care Quality Safety. That led to a review in our residential aged care facilities and the standards of our facilities. I was approached by one of our senior managers in the LHD to conduct some random audits across our RAC facilities in my area, and I cover the central and northern sectors with my renal position. And what we found was that we already knew that malnutrition is quite high in this population, and the risk for hip fractures and prolonged hospital stay is quite protracted in the older population. We also knew that vitamin D and calcium deficiencies have been associated with malnutrition in the RAC setting. In 2020, we looked at some of the data, and there was the Australia-New Zealand hip fracture report, which recorded something like 11,482 hip fractures in Australia, and 20% of the population was identified as being malnourished. So looking at the project and project planning, a needs assessment was conducted. We selected certain sites from the northern, southern, central and eastern sectors of our LHD. And what we found was that there were high rates of malnutrition of residents within the RAC units of our Western LHD MPS sites. And that was all consistent with the literature. There was also high rates of residents that weren't supplemented with vitamin D. So validation. So the population that we were looking at, the literature demonstrated that there was high rates of malnutrition. We knew that there was increased risk of frailty, increased risk of falls, increased risk of fractures, and also increased risk with the hospital admissions due to fractures. So it validated why we needed to go in there. The project aim was to look at trying to reduce our hospital admissions for RAC residents and improving nutritional status of the RAC residents, delay the onset of frailty, prevent falls within the facilities, and also try and improve their quality of life. So identifying the opportunity. So what was proposed was that we were aware that there was Commonwealth funding, and that's where the RAC beds are funded from, but they were providing an additional daily supplement fee, and that equated to something like $1.5 million across our LHD. We have 422 residents, and that was $10 per day per resident. So it's a substantial amount of money that that they were supplementing, and we thought that try and tap in some of that. So what we did was write a brief for the funding for the Allied Health Service Enhancement, and what we're looking at, because it was all focused around the dining experience. The people that we would have greatest impact on that dining experience would be dietitians, speech pathologists, and also an allied health assistant. So again, like I've stated, we have 422 residents across 25 sites. What we were looking at was servicing them face-to-face and also virtual assessments. Our accountability was biannual reporting. We also have monthly reporting to our RAC steering committee, and we just needed to also identify risks. So the risks of the allied health staff being deployed elsewhere for acute measures. So that was one of the risks that we identified, but primarily what we were looking at was servicing the RAC sites. So KPIs were developed around this. We ended up being approved to recruit to 2.21 FTE dietitians, 1 FTE of an allied health assistant, and 1 speech pathologist. That commenced in July 2023. So the dietitian, they essentially conduct nutrition assessments to identify individuals at risk, and they also audit the dining experience. Our speech pathologist conducts dysphagia assessments. Allied health assistants, they assist us with the screening. So we screen using the Edmonton Frailty score. We also have an EAT-10 screen, a SARC-F to assess for sarcopenia, and we also do the quality of life assessment. And then we try and involve virtual physio and OT and on-site clinicians if required. So outcomes to date. So we are now fully staffed with dietitians. So we've got the full complement of dietitians. Not quite got the full complement of speech pathology yet, but working on it. So our occasions of service, so in the first 6 months, so July through to December last year, we did 17 of the 25 sites with initial assessments. 236 of the 422 residents have had an initial assessment. 7 of the 17 initial sites have had reviews. There are 404 occasions of service and 796 hours, 54 minutes of contact time. So we've spent a lot of time with our residents. There's also been a lot of travel time as well. So looking at that, the malnutrition rates are still quite high and consistent with the literature. So 42% of the residents were assessed as being adequately nourished, so with using a subjective global assessment, so they had an SGAA. 45.3% have been assessed as being moderately to severely malnourished, and we were unable to assess 11.8%. So we can assume that there's going to be a significant portion of those unable to be assessed as going to have some degree of malnutrition. Frailty, we use the Edmonton Frailty scale. Again, 26% were considered not frail. 49% were identified as having some degree of frailty. So anywhere from 17% were vulnerable, 12.7 were mild, 14.8 moderate, and 3.8 severe frailty. 25% were not assessed. And again, like malnutrition, highly likely to have some degree of frailty. And the evidence of the frailty suggests that the more severe the frailty, the increased risk of mortality. So with the vitamin D status, when we're looking at screening with vitamin D, 2.9% residents have had vitamin D deficiency or moderate vitamin D deficiency. 8% of residents were mildly deficient, and concerningly 49% of residents have not had their vitamin D levels checked. And again, looking at it, the likelihood of the deficiency rates are definitely going to rise. So in terms of the supplementation, 30.9% of the residents are not receiving vitamin D supplementation. 30.5% have not had their vitamin D levels checked, nor are they supplemented. And the greatest concern is that there's 3% that are deficient and not supplemented. So looking at that, that's our greatest concern. When we're looking at residents that are not supplemented and they're also deficient, they're the residents, and that's the population that are greatest of risk of not just frailty, they're also greatest risk of fractures. So I've completed the first biannual report in December last year. Like I stated earlier, 17 of the sites were completed. We reviewed the KPIs and there were some issues that were identified that needed to be managed. So we had clinical issues and we also had support service component as well. We broke it up into 2 different types. So there was manageable issues versus the unpredicted challenges. So the manageable issues are generally the clinical issues because they're things that are subjective, we can easily measure. So things like the treatment of vitamin D deficiency, screening for vitamin D, frailty screening, and also malnutrition rates. So we can screen for all of that, and we can treat the clinical issues. The unpredicted challenges, and that's like using the implementation tools. So things like food service limitation, resources, including recruitment to our speech pathologist, that was quite delayed. Poor compliance to menu standards at times. Not every site was able to comply to the menu standards. No site is supported by HealthShare, so we have a cook fresh model in all of our sites. Agency nursing and staff turnover, and we also have like a locum GP service or virtual rural generalist service, so where there's no GP. So there's a lot of factors there that's outside our control. So the other things that we were looking at in terms of our next slide, sorry, food service limitations, is looking at the site ownership. We're looking at ownership by the staff at the facility, dividing and conquering. So getting our clinicians to divide the 25 sites and establishing networks and rapport to empower change, investigating into standardisation of food supply, and provision of further education to nursing, food service and medical officers. So one of the things was that where I've started the investigation is looking at our market basket survey. So that's just looking at the price of food in each of the individual towns, and then looking at where they're accessing their supplies from. Do they get it from the local butcher? Do they have a supplier that comes in? And a lot of the times there's great issues in terms of just food accessibility, or it might be the quality of the fresh produce in the more remote towns. So some of the reflections and lessons learned. So known clinical issues are prioritised and are manageable with collaborative stakeholder engagement. Many unpredicted challenges presented themselves during the pilot that weren't foreseen. So looking at it, the main challenges were predominantly related to our support services in the healthcare environment. So again, the high cost of foods and related to distance, availability of resource, difficulty in recruiting to allied health clinicians, even with incentives offered, limited access to food service suppliers, limited choice of additional food choices. So it's going to be, when we're trying to look at improving the dining experience, we've got a lot of limitations around our food service supply and the budget and cost related to food and the provision of food. So we're trying to improve the food service delivery and the food service standards, but we have a lot of barriers that we need to overcome. Hence why looking at standardisation of food services might be one thing that we could be looking at. These challenges are being addressed with our senior executive, and obviously we're looking at implementing some innovative ideas. So looking at it and going full circle, so what we find is that the vigilance of vitamin D screening for the prevention of vitamin D deficiency is really important. Awareness of vitamin D deficiency in the elderly. So just simple things like exposure to sunlight where possible, as this has benefits from a mental health and also a wellbeing perspective. Identification of frailty to prevent falls, early identification of malnutrition and symptoms of malnutrition, reinforcing the key nutrition messages of protein, calories and calcium to prevent malnutrition. So our biggest thing is let them eat cake and custard. So special thanks to Diane Harvey and Elizabeth Jeffries. They were foundational in the support and getting this project up and running. So I'd like to take a big thank you to both of those individuals. They have done an amazing job to support me in getting this project up and running. Contact details are there if you'd like to call me about the project. Thank you.